Hey, it looks like it's slowed down a bit, but I know people will be coming in as we're going through the slides. So I just want to welcome everyone. This is our first AFT work group meeting of 2025. And we are very excited for our presenter today. Dr. Ramzi Salloum will be talking about investigating adaptations in the context of program sustainability. The case of Cancer Center Cessation Initiative. And just so you know, we will be posting the recording and accompanying slides to our website, and I will put all of these links in the chat at the end of the introduction. So just a few news and updates. The University of Colorado Accords D&I certificate program is still accepting applications. This program is a graduate program focused on training you in D&I research and also kind of the more theoretical pieces of being able to conduct D&I research. Next is the Colorado Pragmatic Research and Health Conference, or CopperCon. This happens every year and is hosted by the University of Colorado Accords program. It has the purpose of training and engaging researchers in methods and applications that support research for having a real-world impact. This year's conference theme is the future of pragmatic research, team science to enhance innovation and impact. So abstracts are still being accepted until the 15th. So you have a couple days, and then the conference will be held in Denver, Colorado at the University of Colorado, June 4th and 5th. And then we wanted to promote our January DISC seminar. So this is happening on January 30th. This is not our typical schedule of the third Thursday, but we are really excited to have Dr. Elizabeth Waybright and Samantha Harden present on dissemination implementation science with the cooperative extension system. And again, I will be putting all these links in the chat afterwards. For our upcoming 2025 meetings, we are actually booked out until May, possibly June, so that's very exciting. We have an amazing list of presenters, and all of these are posted on our website as well. But if you are interested or know of someone who might be interested in presenting the later half of 2025, please send a nomination form through our request system, and I'll put that in the chat as well. We've gotten some really great presenters and topics through that way as well. So we're really excited for our upcoming meeting. Now I'm going to pass it over to Russ to introduce our presenter.
Thanks so much, Kara. And it was great to see at least some of you at the D&I meeting, the Academy Health meeting last month. Just one other housekeeping note from me. Please do use chat liberally. I will track as Dr. Salloum goes along, and then I'll queue up questions. And then if there is something kind of urgent or pressing, can maybe engage in them. But generally, we'll let Ramzi go through with his talk, and then I will try and help him facilitate the questions. So let me just do a brief introduction. Dr. Salloum is a professor and division director for implementation science and health interventions in an interesting department that is of both health outcomes and biomedical informatics at the University of Florida College of Medicine. Ramzi has a number of roles. I'm not quite sure how he does it all, and is still as prolific a researcher. But he's, in addition to those titles, he's Associate Director for Community Outreach and Engagement at the Florida Cancer Center. He'll be talking about some of that work today. His work focuses on cancer prevention and control, both in the U.S. and in global settings. He's been well funded by a variety of institutes, has authored over 200 peer-reviewed publications. And I'm particularly excited. Today, he's going to talk with us about the role of adaptations as part of a sustainability of a national collaboration across cancer centers. And I'll let him take it away there. Ramzi, it's just so great to have you, and really appreciate your doing this. Look forward to great discussion.
Thank you, Russ, for the wonderful introduction, and good morning, everyone. Good afternoon for those of you on the East Coast. Really honored by this invitation to present on some of our work today. Before we begin, I'd like to take a moment to acknowledge the fires affecting California and the challenges so many are facing right now, and my thoughts are certainly with everyone who's impacted. I'm going to take time today to present on an NCI R01 that started about a couple of years ago. We're still in the early stages of going through our findings and going through next steps in terms of studying sustainability of this national initiative. So before I begin, I just wanted to acknowledge my funding sources, primarily from the National Institutes of Health, and no relevant financial relationships to disclose. So today I'm focusing on our work on the Cancer Center Cessation Initiative, which is a moonshot initiative that implemented or supported the implementation of tobacco cessation programs nationwide for a period of 5 years. This work built on previous efforts over the past decade to recognize the benefits of tobacco cessation in cancer patients and survivors. Starting with early work that recognized that even at NCI designated cancer centers, these programs are few and far between at the time. This is around 2013 is when this work was published. And then in 2014, the Surgeon General's report, there was a Surgeon General's report summarizing the evidence to date on the health benefits of smoking cessation in cancer patients. And this culminated with funding of the initiative of the Cancer Center Cessation Initiative in 2017 with moonshot dollars. And again, the initiative then led to a publication, the NCI Tobacco Control Monograph, that focused on this topic in 2022, which summarized the evidence, saying that quitting smoking is among the most effective treatment options. So again, emphasizing that tobacco cessation is a treatment option that's available to cancer patients and survivors, rather than simply a behavior change activity, in improving the likelihood of survival, quality of life, and overall health. So this builds on an extensive evidence base, but as is the case with many of our implementation research problems, there are barriers to implementation. And so, and there are multi-level, and those are summarized in the tobacco control monograph, from the patient level, barriers that anything that you could imagine in terms of barriers faced by cancer patients and survivors, to clinician level barriers with respect to time, training, access to resources, and prioritizing smoking cessation in the context of cancer treatment is usually a problem both for patients and clinicians. And of course, these are exacerbated by system level barriers related to insufficient reimbursements, insufficient policy supporting tobacco cessation in cancer care settings. So as I mentioned, the C3I, or the Cancer Center Cessation Initiative, started in 2017 with a cohort of 22 NCI designated cancer centers that were competitively selected. The funding mechanism was a supplement to the NCI Cancer Center Support Grant, the P30 mechanism. And so the first cohort was funded for 2 years, and then a year later, another cohort of 20 sites were funded across the US, and finally in 2020, another 10 sites, and in addition to some of the existing sites receiving additional enhancement funding at the time, were funded for 1 year only, resulting in 52 of the 70 NCI designated cancer centers receiving funding through this initiative. With funding came the expectation that these programs would be sustained beyond the funding period. So cancer centers were required to provide a letter from their director ensuring that that the program would be sustained for at least 3 years beyond funding, and a sort of a loose sustainability plan that would be describing how these programs would be sustained beyond the initial NCI funding. It's also important to mention that even though for the majority of cancer centers, they did not have a smoking cessation program prior to C3I, for a minority of centers, they did in fact have tobacco cessation programs in-house, and those have been in some cases functional for many years, and so the funding was used to enhance the services that were provided at these programs, and perhaps strengthen the sustainability of those programs. So unlike other implementation research projects where you usually have a randomized trial design, in this case, we are studying a sort of a natural experiment, an actual implementation initiative, where the funder did not specify how to develop the program, or and allowed sites to actually design their own programs in a way to fit to maximize or optimize the fit of these programs based on inner setting, outer setting, and the needs of their patients. So programs had a menu of different services and components to choose from in designing their programs to maximize this fit. And so that is a wonderful part of the design of this initiative. It also makes it more challenging to evaluate, especially retrospectively. One benefit of having the Cancer Center Cessation Initiative was that I mentioned. I'm going to go back here to the University of Wisconsin-Madison, which serves as the coordinating center. So there was a coordinating center. There still is a coordinating center for the initiative. And the coordinating center has done a wonderful job at standardizing the assessment of the initiative. The coordinating center, along with an expert panel, developed measures for evaluation, common measures for evaluation. It's no surprise that they were using the RE-AIM framework to guide their assessment, given how simple and flexible it is to capture this heterogeneity in terms of implementation. And so the C3I uses RE-AIM for evaluation, and during the implementation phase, there was an assessment of sites, particularly reach and effectiveness, in addition to other implementation measures every 6 months during the funded period. And I've had the fortune of collaborating with the coordinating center even before this R01 on sustainability was funded. Initially working on characterizing implementation costs of the smoking cessation programs, And so fortunately, we've had access to the evaluation data from the implementation and even the pre-implementation phase, the data that were collected by the coordinating center. This is as of 2022, when the funding was wrapping up across the different sites. The C3I was able to demonstrate a huge impact on the practice of providing access to smoking cessation services among oncology patients. More than 100,000 oncology patients across the U.S. were reached by the tobacco treatment program. And in terms of effectiveness, it was able to demonstrate that more than 20% of patients who received tobacco treatment reported that they were no longer smoking at 6 months. In terms of equity, there was also demonstrated impact across all patient populations, particularly underserved populations, including women, older patients, Black, Hispanic, and those covered by Medicaid, Medicare, or the Indian Health Service. So as I mentioned, programs were required to submit sustainability plans as a part of their application process for the program. Given that the program or C3I was already using REAIM for assessment of implementation outcomes, when we started thinking about sustainability. So when I got involved with the program, with the initiative, my initial focus was on evaluating costs, given that my training is in economics. That quickly led me to start thinking about sustainability. And again, around the same time, there was this wonderful extension of REAIM that was published and describing the natural synergy between REAIM and costs and sustainability and health equity. This is Rachel Shelton and David Chambers and Russ's publication around the extension of REAIM. And so it made sense. We were already thinking about the dynamic sustainability framework as our determinants framework for understanding sustainability. So recognizing the link between or the really critical influence of implementation and operations costs on sustainability of the initiative, which is the stated key outcome by the initiative. This made sense for us to be thinking about this framework as a guiding framework for us. So about a couple of years ago, we received R01 funding to study sustainability. We are fortunate that we had been working with the initiative, as I mentioned, for several years at that point. We had been working with sites. We had a sustainability working group formed with the sites, with the C3I sites, which function more as a learning collaborative, and we were able to work with sites even during the implementation phase into the sustainment phase to collect data, interpret data with and best practices with representatives from and scientists from those sites. And so what we proposed was to follow an implementation mapping approach to study sustainability, trying to uncover and really retrospectively understand what implementation strategies were used to influence the determinants of sustainability. We were also fortunate to be able to start collecting data prior to the R01 on using the clinical sustainability assessment tool to measure determinants of sustainability in a quantitative fashion across the sites. And so then using mapping these determinants and strategies to outcomes is sort of our goal of using implementation mapping to develop or come up with generalizable knowledge on this experience with respect to sustainability. And then as we started thinking about the sustainability assessment in the R01, we went back to some of the early literature on sustainability. This specifically this paper by Shearer and Deering to define sustainability outcomes. And I have to say that when we were writing the different iterations of the proposal, we struggled with how to define sustainability in this case, and how to define sustainability outcomes. We obviously were interested in sustained health benefits from the program, in this case, impact on smoking cessation among cancer patients. But we also recognize there are many different dimensions to sustainability, particularly the ability to maintain practices, procedures, and policies in these programs, including being able to continually monitor outcomes, which was an expectation during the implementation phase, but we also knew that it's not realistic to expect that expectation would continue after funding across all sites. So continued program activities was another dimension. Maintaining partnerships is another critical dimension that was introduced in the Shearer and Deering article. And then also thinking about scale-up, diffusion, replication as another dimension of sustaining these programs. And so I'm going to present today some of our early results from our mixed methods evaluation that we're conducting as part of the R01. We have a lot of limitations given that this is a retrospective analysis at this point, and our unit of analysis is the organization, so we have a small n. So in 2023, between 2023 and 2024, about a year ago, we conducted our sustainability assessment through a Qualtrics survey that went out to the sites. The sites had the option to complete the survey individually or via group consensus. We included assessment of program status at that point after the end of funding, which varied based on what cohort the centers were in. And we also assessed the clinical sustainability assessment tool, in addition to the program sustainability assessment tool, which I'll talk about in a minute here, and financing strategies, as well as some of the sustainability outcomes. We also, our plan was to follow the survey with qualitative interviews with the centers. So we've conducted 20 interviews with 20 sites. I'm going to talk today about results from 10 of the sites focusing on adaptations. We tried to, this is incomplete here, but we also did some purposive sampling to include sites that had above median reach and some that had below median reach in the sample. We also made sure that we had sites that were non-sustaining as well as sustaining sites in the mix to understand both experiences. And in terms of the analysis of adaptations, we used the frame template, the published template of the frame, to guide the extraction of data on adaptations. So speaking of adaptations and Fidelity, we realized after the fact at the time of studying sustainability that we don't have a common understanding of core functions in the initiative. That was not necessarily something that was defined by the initiative early on, although it was implied that folks knew what tobacco cessation meant in the context of cancer care settings. So I have to say that this iteration of core functions was developed by our working groups and our R01 team after the fact, working collaboratively. So after the initiative had been implemented, yet we're using this to guide our assessment retrospectively now. So this is basically what we came up with in terms of core functions for an implementation initiative that had a lot of heterogeneity in terms of what components were included in these tobacco cessation programs from the menu of options that I showed earlier. And so we identified screening patients, advising them in the clinic about the harms of tobacco, and referral, which is typically your ask, advise, refer intervention, the brief interventions in clinical settings that are supported by the guidelines, and then offering treatment, some form of tobacco treatment, tobacco use treatment, as well as the ability to evaluate tobacco treatment outcomes as our core functions. So in terms of the sustainability survey, we had a great response. Again, we are grateful for the collaboration of these cancer centers. This is being done after their funding has ended. So we had a response rate of 90% across the 52 sites. And we learned that 83% of the sites that did respond were still operational at the time. This was about a year ago. And then we assessed what we could in terms of the core functions. And it's great to see that for the most part, these core functions are still maintained after funding, with, again, varying degrees of time since implementation due to the cohort effects. And it's also, we also see here reflective of the sort of the difficulty of maintaining each core function is reflected in the results going from screening to actually measuring and maintaining effectiveness of treatment. So these are tobacco treatment program forms that we were able to assess over time since the sustainment phase started. These are the same. We chose these forms because they were assessed during the implementation phase by the initiative. So we tried to follow the same forms or components that were measured in the past. And again, we see that some of the key forms that we look at is the ability to report on outcomes using the EHR, automatic reporting, in addition to EHR modifications, which for the most part we saw have been maintained across the sites. In terms of the sustainability outcome of looking at program diffusion as a one dimension of sustainability, we saw over time that a lot of programs started their implementation in medical oncology and radiation oncology. And over time, we're seeing some evidence of spread to other settings, again, starting with the C3I effort in oncology, going to primary care and other specialties. So this is really, again, this is descriptive, but this is promising to see that there's evidence of spread directly attributed to the initiative. In terms of the clinical sustainability assessment tool, which again was developed by Doug Luke at Washington University, St. Louis, and his team. This is a tool that assesses 7 different dimensions of sustainability capacity, which we're using as a determinant here. And we're still digging into the results of the CSAT. But in terms of the cohort effects, what we can see here, and again, with COVID-19 as in the background here as additional context, that I think the key story is the ability of the later sites to converge in terms of capacity, quickly converge, thanks to the network effects and the learning collaboratives that were developed and the resources were developed by the initiative over time. So we were able to see, despite COVID, that the later cohorts were able to benefit from the experiences of the first cohort of sites. So in the sustainability survey, we realized that even though we had been assessing the CSAT for several years at that point, that we were still missing factors that we found out were in the other tool that that group developed, which is the program sustainability assessment tool. So the PSAT was developed earlier. It was targeted at public health programs, whereas the CSAT was an adaptation for clinical settings. We realized at that time that in our case, we were studying the implementation of tobacco cessation in a clinical setting. We had to borrow domains from both tools, and from going to DNI and other meetings, realized that we were not unique in that sense, that other researchers have been doing the same thing. In this case, I think the biggest reason for this is that we are looking at a service that doesn't generate enough clinical revenue to be sustained. So it functions in many ways as a public health program, even though it's in clinical settings. So then we went back and identified 4 domains from the CSAT that were not duplicative with the CSAT, and that our experts and users thought were critical. So we used those in our survey. What we found out, surprise, was that program adaptations were ranked high among sites that continue to be able to report to us on sustainability. That was their ability to adapt their programs was important for sustainability, and that's probably, again, thanks to the design of the program in the first place, and maybe it's a result of there's some circular logic here with the results of sites being overwhelmingly sustained thanks to adaptations. We saw that the lowest ranking overall, the lowest ranking domains were funding stability, and within the CSAT was organizational readiness that was rated lower at that time during the sustainment phase. Implementation strategies were also not something that was measured in a systematic way during the implementation phase. So we're also doing some crowdsourcing to identify what implementation strategies were used using our sustainability working group from the sites, and then we included these implementation strategies in the survey to assess which sites actually used them after we identified the most important and most feasible implementation strategies that were discussed in a brainstorming exercise that we did over the course of a year. And so we tied the way we identified the implementation strategies was tied to the CSAT domains. Under each domain, we worked on brainstorming the implementation strategies. And then so we've been able to assess which ones have been maintained, which ones are no longer in use at the time of the survey. And in terms of overall these implementation strategies under each domain, we in our early findings, we were able to compare the sites that are still operational versus sites that are no longer in operation. We saw one of the biggest differences between the sites is under organizational readiness, perhaps suggesting that this is a really key domain for us in this case in terms of maintaining operations. In terms of financing, because financing was not part of the CSAT, we ended up asking separate questions to better understand the financing picture here for the programs. We saw that the majority of programs, or at least the most common budget range, was 100 to 250,000 across sites as the highest annual operational budget. That didn't really change drastically in the last year that we assessed this in 2023, although we did see a dip in overall in funding across programs. And what programs told us is that what they felt they needed to have an optimal program was really only about $50,000 was the most common response that we got from sites. We also asked about the types of financing strategies, and for the most part, the single most common source was institutional support. Again, this is not a service that relies on or has sufficient revenue to be self-sustained. Although we did see some evidence of reimbursement, fee-for-service reimbursement, and very little in terms of bundled or episode-based payments. And there's a little bit of evidence that suggests that sites that are still in operations had more diverse streams of funding, which was what you would expect in this case. In terms of maintaining partnerships, which is another dimension in the sheer endearing conceptualization of sustainability outcomes, we asked sites about which partnerships were maintained, and we saw a natural progression in terms of stronger maintenance of partnerships and inner setting type partners as opposed to outer setting partners in this case. So when it comes to adaptations, we, aside from the question that was the questions included in the PSAT, which we're still analyzing, we went back to our interviews, which were just getting started in terms of analyzing. We were able to look at 10 of the 20 interviews so far before this meeting or before this presentation, and try to categorize the different occurrences of mention of adaptations across our interviews using the frame template. So this is a summary of what we're just starting to learn about adaptations. Again, keep in mind that this was done retrospectively, and it's really difficult and several years removed from the implementation phase. So we're really relying on recall here to tell the story about adaptations. So in terms of when these adaptations that were most critical, perhaps, that emerged in the interviews occurred, most of them, the vast majority of them, are occurring in the sustainment phase, which is expected given that this is when the way that we've defined our phases is according to funding. So the implementation phase we're defining as the period of C3I funding in this case. And so it's as a consequence of loss of funding, we're expecting to see a lot of adaptations. Of course, adaptations that happen later on in the implementation lifecycle can be more costly. And so that's perhaps an implication or consequence of these adaptations that we're yet to learn about. We also, in terms of planning, we also, as I showed on an earlier slide, this study or this initiative occurred in concurrence with COVID pandemic, and so we, of course, saw a lot of changes, mainly offering services through telehealth, just like other types of health services during that time period. And so, but what we're learning is in terms of that whether these changes were proactive or reactive, for the most part, we're seeing that we had some reactive adaptations that were mentioned. But for the most part, the ones that were discussed or critical to be discussed in interviews were planned, so which suggests that what we would expect is that in the early phases of COVID, there were probably some unplanned reactive adaptations that later changed to planned adaptations that were more or better thought out in terms of planning for alternatives. In terms of who was making those decisions, we see here that it was primarily originating from program staff. And at least what we're seeing in the transcripts so far is that the nature of these adaptations are, for the most part, related to tailoring of the program rather than substituting or changing the services that were provided in the programs.
Yeah. Ramzi, excuse me, just a second, a quick time check. You may be right on schedule, but if you could maybe wrap up this part in the next 4 or 5 minutes so we have time for questions and answers, that'd be great.
Thank you. I didn't realize. Thank you for the time check. I'm actually very close to the end here. So, okay. So then in terms of being able to measure fidelity, of course, this is really challenging given the design of our study. Being retrospective, again, observational, but it's we used core functions that we defined after the fact. But at least what we're able to ascertain so far is that most of the adaptations have been fidelity consistent. And in terms of the goals, we're seeing it's no surprise that the leading explanation is reducing costs in the face of losses of funding, increased reach. We're seeing, which is very good to see, and then some of these other reasons that were provided. And I have some quotes here, but in the interest of time, I think I can maybe stop and take questions. I see that there's a lot of questions in the chat. I'm going to skip over these quotes. I might come back to them if that helps in terms of answering questions. I did want to say that this work is ongoing and that we are continuously updating the toolkit, which we hope to develop specifically for sustainability. So we're working with the coordinating center at the University of Wisconsin, and we hope to continue to update the initial toolkit that we're developing on the C3I website that's available at the link that's mentioned here. And so we'll continue to share what we learn if you visit the tobacco treatment implementation roadmap. And then finally, I wanted to acknowledge a very large team that's involved in directly with the R01 and through the sustainability working group. Especially grateful to our wonderful project manager, Magda Montague, who's on the call today, and the rest of the UF team. And also wanted to call out Mara Minion, who's the project manager at the C3I Coordinating Center, who's currently on leave and couldn't join us today, but just really lucky to be working with a wonderful team across many C3I sites across the country. Thank you.
Ramzi, thank you so much. That was an incredible tour de force. And I'm not sure if I've seen such a great integration of so many implementation science frameworks and things, and it also a great adaptation from my perspective of, quote unquote, natural experiment, what's happening about a critically important issue there. So that's really superb. Let me start off, and others please continue to enter in questions. But there was a question about on the functions, the core functions framework. If you were using the Perez, Yoles, Mittman type frame, or if that was from CIFR in terms of talking about the core functions, how you develop those.
Yes, it was mostly the former that informed
Yeah.
our work to try to define the core functions. We also hope to develop that into a publication that would be useful to the practice of tobacco cessation implementation. So, but yeah, it's mostly informed by the Monica Yoles Perez and Brian Mittman conceptualization of core functions and forms.
That was, I will just editorial comment. I think that was great. And the fact that you were able to, do that kind of somewhat retrospectively and group. Just in general, how did that work for you? Did you feel like that framework worked? And then if there's any of the other ones that you use, I was just making as a note you went through, you use not only re-aim, but implementation mapping and frame and things like that. So I know that could be a 2-hour conversation, but maybe starting with the function and form, did that work pretty well for you in this application? And if there's any of those other ones you'd like to comment on that worked either really well or didn't work so well?
Yeah, I think so. I mean, it's hard to do this work retrospectively. We do have the benefit of continuing to work with the implementers. And one thing I'll mention is that perhaps C3I may be different in this perspective, maybe not so different, is that given that this was a cancer moonshot initiative, the implementers are, for the most part, researchers, not what you would expect. They're not, administrators or uh, exclusive clinicians. So we were working with like-minded researchers. So for us, it was easier to that receive the funding to do this. So it was easier to continue to work. These are all colleagues and have been very generous with their time to help us go back and reconstruct the pieces of the puzzle when it comes to core functions and forms. So I would say it was, really helpful in terms of guiding the conversation and thinking about what really was a core function versus a form, and being able to reference that framework in the collaborative conversations that we had to develop these. I think it would be more difficult to do this if our implementers were not researchers, because there was a common understanding of what this is, and they were able to go back. I mentioned the opportunities and challenges with using the CSAT and the PSAT. And so I think I wish we had realized this earlier and been able to collect more data on the PSAT domains. But we're glad that we were able to collect this in the current survey. Let me see what else we are. I think the next step for us is to be able to see. We're not going to be able to come up with anything causal, but we want to be able to look at least these adaptations classified by goal, any associations with survival of the programs or some of these program outcomes. So this is going to be our next step. So stay tuned for that. But we'll be able to look at some associations, and then the NCI has announced a initiative in the fall to fund randomized control trials in this domain in 2025. So there will be hopefully projects funded that will be looking at this from a randomized control trial implementation trial perspective. So we're going to have some limitations in terms of our findings here with the observational design that we have.
Super, that's great. Have one new question, and I'm going to try to convey it correctly here from Gretchen. Gretchen, feel free to take yourself off mute if I don't gather it here. But she was very interested, especially given your role in community outreach and engagement, cancer centers, how the external partnerships came up, and if you just have any comments on the role and importance of those in your analysis.
Yeah, so I don't have, that's a great question. I don't have anything scientific to respond with just yet. We are still analyzing those data. I have to say that anecdotally, it's, we see these with programs that have tobacco treatment integrated into their community outreach and engagement strategies. We do see stronger, anecdotally, we see some stronger programs when this is integrated into the community. In my role as Associate Director for Community Outreach and Engagement, I've had the privilege of visiting some of these cancer centers and centers that have been able to fund tobacco treatment specialists as part of their community outreach and engagement, have been able to successfully do this for several years. And many of the experts, the implementers in C3I have proposed this as a sustainability strategy, is to include tobacco treatment programs in the Cancer Center Support Grant. Of course, the NCI, I don't know if we have anyone from NCI on the call today, but they're always ambitious in what they ask cancer centers, and so it's always a challenge in terms of prioritizing things in CCSG grants and cancer center support grants. But there's been a call to include smoking cessation, just given the centrality of tobacco cessation to cancer outcomes.
Oh, great. I might venture to guess, at least somewhat in part, to the great work you and the others on this initiative have done there. I don't want to monopolize here. I encourage people to keep entering other things in here, but I would like to prompt a little bit, Ramzi, and maybe give you a chance to editorialize a little bit, given your somewhat unique background, I think, as an implementation science with your economic background too. I was interested in seeing that, but not only the specific economic issues you brought here, but from my perspective, the whole integration of economics and implementation science is just so critical. And I think until the last couple years, led by people like you and the consortium and things like that, has really been underemphasized, but I think especially for sustainment. So it's not really a question, but I guess just to give you an opportunity maybe to articulate and give some of your thoughts about this and where this might go in terms of the future integration of the fields even.
Great, thank you, Russ, for your kind words and for this important question. I think I've been privileged to participate with you and others from the VA and across universities across the US in this working group on the economics of implementation that I invite everyone in the audience to review some of the publications that have come out of this group. I want to start answering this question by going back actually to one of the quotes that I had, so that I wasn't able to cover. So this came from one of the cancer centers. One of the questions that I often get asked when I'm requesting a new clinical staff to actually see the patient is, do you need more administrative support? Because if you do, that's not funded. Like, we're not moving forward with this if you're requesting more support staff. So so this is characterizing a veto on administrative support staff for programs from the decision makers at that cancer center health system. And I think this is really critical because we often, when we think about health economics, we think about cost effectiveness analysis. And sometimes it's not the cost effectiveness that really drives initial implementation or continued implementation when you're relying on an external force to support funding. You can give your administrative leaders information about cost effectiveness all day long in the context of tobacco cessation, but it's not going to drive them to support the program because the benefits of the program may not directly be attributable or directly go back to your health system. In fact, there may be unfortunately lost revenues as a result of treating cancer patients for smoking cessation or for smoking, unrealized revenues from expensive cancer treatment. And so it's again, it's more about what's in this quote about realizing how you can do this with the resources that are available in the health system, whether there is capacity, unused capacity. We did a paper on efficiency of the smoking cessation programs in NCI using the cost data that we collected and some of the outcomes on reach and effectiveness. So again, it's about the looking at the operations costs, perhaps conducting a budget impact analysis if it's helpful in the short term for when you're looking at the health system perspective as a decision maker, rather than looking at the societal perspective, especially when we're talking about a system where we don't have universal health coverage. It's not a single payer system. So again, thinking really at which the perspective of the payer is really critical, and what's going to matter in this case. Are there resources existing rather than, or resources that the health system is willing to contribute or invest in, rather than, in this case, the cost effectiveness from a societal standpoint.
Thanks so much. Yeah, so rich in the perspective in there. I would echo Ramzi's encouragement to look at the series of publications that have come out, and just call out Todd Wagner from the VA and Gila Netta from NCI were particularly instrumental in pulling this group together. And you can see a number of those in implementation science. We probably should wrap up here. Ask Kara is going to remind us and maybe put in the chat, if you can't see it already, that this session will be recorded. I know there are a number of our members that weren't able to make it, but are very interested in it. So again, I'll just close by thanking you so much, Ramzi. And I'll just say we're really look forward to seeing the publications that come out of this. And thank you for sharing. I just thought it was beautiful, and you kept kind of apologizing for this being retrospective, but I'll have to say it's true with all the appropriate caveats, but I think this sort of real world analysis of what happens, particularly for sustainment, is just so critically important, and we can learn so much from it. So congratulations to you, and thanks again so much for spending the time and this great experience with us.
Thank you so much, and I want to say thank you to the audience as well. Thank you for your time.
Take care, all.
Take care.